Welcome to the Stanford Women's Health Vodcast series. I'm Dr. Sharon Hung, Director of Women's Health for the Primary Care and Population Health Department at Stanford. From debunking myths to exploring the latest research, we will delve into the world of women's health with leading experts in the field. Dr. Chwen-Yuen Angie Chen is an internal and addiction medicine physician at Stanford Health Care and clinical professor in the Division of Primary Care and Population Health at Stanford University School of Medicine. She serves as the medical director of the Embedded Primary Care Chemical Dependency Service, as well as chair of both the Opioid Task Force and the Wellbeing Committee at Stanford Hospital and Clinics. Dr. Chen has conducted research in methamphetamine, cocaine, and MDMA and has co-authored papers on the use of large learning models, opioid use disorder treatment, and physician suicide. She is also passionate about supporting impaired physicians in their recovery and reintegration into practice and dismantling licensing processes that stigmatize physicians with mental health and substance use disorders. Dr. Chen, thank you so much for being here today.
Thank you.
I wanted to start by asking you what motivated you to specialize in addiction medicine?
I've been interested in this area for a long time, since an undergrad in film school in New York City, and I did some research as a medical student in adolescent substance use disorders as a Gene Spurlock Fellow. It's a field that I've discovered allows you to see substantial transformation in people's lives. I didn't get the same satisfaction managing hypertension, diabetes, and not that those are bad things, but I see not only physical health improvements in people when I treat them for their substance use disorders, but also this psychological and spiritual change.
Yeah, and you have helped so many of my patients, so I can see how that transformation would be very rewarding to see.
It is.
So can we start by defining substance use disorders? And I also learned from you that we're no longer using the term substance abuse, if you could comment on that as well.
Yeah, that's correct. We no longer use this binary term of abuse and dependence. Oftentimes I say that the substances abuse us more than we are abusing it. It's changed to a spectrum. According to the DSM-5 Diagnostic Statistical Manual of Mental Health Disorders back in 2013, we've really are now using an 11-point criteria to diagnose mild, moderate, and severe use disorders or addiction on a spectrum. And so there's also harmful and risky use as well. NIDA, National Institute of Drug Abuse, ironically, abuse is still in their title, defines addiction as a chronic, relapsing, and remitting disorder that's characterized by compulsively using or seeking a substance, continued use despite harmful consequences, long-lasting changes in the brain, that occurs through this chronic exposure. So it's considered both a complex brain disease as well as a mental illness. Addiction is the severest form of a full spectrum of substance use disorders. It's both a medical illness caused by repeated overuse of the substance or behavior, and that whole process is very complex.
I see. And I know when you first heard I was doing this women's health podcast, we had a conversation about having you on the show. So can you elaborate for us why this is such an important women's health topic?
Yeah, so first of all, substance use disorders, addiction is an important global health topic for both men and women. It's underdiagnosed, undertreated, misunderstood, and deeply stigmatized. And it hits women and women's health in far greater, in the sense that it's given short shrift, just like other aspects of women's health, like cardiac disease. For so long, research has been done in that 70-kilogram male. And so we know a little bit more, but not enough, about how these treatments work for women, what works best for them, how they affect women differently than they do men, especially the maternal fetal dyad, women of childbearing age, hormonal cycles, how that affects how substances are metabolized in women. So it's an important topic to talk specifically regarding women. And also over the years, substance use, especially alcohol use, has just skyrocketed in women, especially during the pandemic.
Yeah, it's really unfortunate that we have that knowledge gap, but I'm so glad we're raising awareness today. So, how common is and what are the recent trends in substance use disorders in women?
So the trends are that in general, globally, men still use more than women. That gap is closing specifically for alcohol use disorders. And what is concerning to me is that gap is not only closed for adolescent girls, so the age between 12 and 17, but that girls have surpassed alcohol use than boys of that same age. So 3.8% for girls and 2% for boys. And so those girls grow up to be women, and you have to think of the maternal fetal dyad. We know that if people start younger, they are more likely to develop a use disorder later on in adulthood. So that's concerning there. Um, and this gap is also not there between men and women if you come from a higher socioeconomic place. So, urban areas in the United States and globally, like Sweden, this gap is not there. So, women drink as much as men do.
Wow, I was not aware that the rates of use of adolescent females was higher than adolescent males. So, what are
Yeah.
some of those specific risk factors for substance use disorders that are particularly prominent in women?
I would say trauma, adverse childhood experiences, intimate partner violence, and the way one's partner uses will affect the way a woman uses um, in those relationships. And then I want to highlight at this time also the prevalence of all polysubstance use, all substance use disorders, especially for transgender adults relative to their cisgender counterparts. And especially for trans femme people who are assigned male at birth. So if we know that males who, if you're assigned male at birth, then biologically, physiologically, you respond to substances in a certain way, and there's a higher use. And so we have to be sensitive to this population and screen accordingly. And they're also, uh, they have a greater intimate partner violence and mental health disorders. So I wanted to highlight that because it's often not addressed.
Great, thank you for bringing that up, and we'll delve into that further as well. And we are learning more and more that there's probably no truly safe level of alcohol. Can you talk about our current knowledge and recommendations of safe levels of alcohol use?
Um, so currently the guidelines are to reduce harm to drink one drink per day or no more than 7 drinks for women. That's and 14 it's higher for men. But our neighbors rather north of the border in Canada have recommended to avoid um, the consequences, the harmful consequences of alcohol use to drink no more than 2 drinks per week, which is dramatically less. When I tell patients this, they're kind of astounded, like, "No way, I can't do that." And adoption is probably going to be slow south of that border. Um, but Lancet came out with uh, um, a report back in I think 2016 or 2018 that said something about no safe levels, which was very controversial because what they found was there wasn't much of a difference between not drinking at all and low levels of drinking. And so how can you make that determination that you really shouldn't be drinking anything if there isn't a difference between low amounts of alcohol use? The other criticism was that this was a very large cohort that they analyzed, and you can make sort of conclusions based on trends, but you can't speak about the individual. And it is true that some people seem to be able to drink without much consequence to their body and to their surroundings. So, but with that said, that's why I like the Canadian guidelines, because it gives you sort of a grade of like levels of like, if you drink nothing, then you will benefit from not drinking. And then if you drink two or less, then you'll probably avoid most of the consequences. It's primarily cancer. And then if you drink from 3 to 6, you may increase your risk for cardiovascular diseases. 7 and above, you just have an overall risk for many, many consequences. And then each one greater than 7, then, you just stack on the harms. So that kind of puts it in perspective and allows you to choose what risks you're willing to have.
Thank you for highlighting some of those other consequences, because I think a lot of patients know that there's an impact on their liver, but they're not aware that even low, moderate consumption in women can increase the risk of numerous cancers, including breast cancer. Can you talk a little bit more about how alcohol affects women differently than men?
Sure. Alcohol use in women, there's this concept of telescoping. And so their use will more rapidly escalate into problematic use and use disorders with greater consequences. So because we metabolize alcohol differently, it takes less alcohol. If you compare like the same amount of alcohol for men and women, we will have a higher blood alcohol level. So less alcohol, more damage. It also contributes to intimate partner violence. And then what's interesting is uh, early on in my practice, I discovered I had a lot of bariatric surgery patients, and discovered that, those who get bariatric surgery, especially Roux-en-Y procedure, tend to develop very rapidly an alcohol use disorder. And that's because you're anatomically changing where alcohol is metabolized. 20% of alcohol is metabolized in the stomach. Women already have a reduced amount of alcohol dehydrogenase, the enzyme to break down alcohol, and then you just lop off that part of the stomach altogether. And so it just goes straight into the brain, all that alcohol use. Alcohol is a toxic substance. Anybody who's taken OChem knows that. And and so it accelerates aging, it impairs immune function, it creates a leaky gut, it's a depressant, it contributes to suicide risk. I mean, there are a lot of downsides to alcohol use. But I also recognize, and my patients tell me, that there are the upsides of alcohol use. And so you have to balance that with it being a social lubricant. It's enjoyable, it's stress relieving, it creates social bonding. So those are the things to factor in about alcohol use.
Yeah, and in terms of assessing that risk, I routinely ask people how often they're drinking, how many drinks they're having in a 24-hour period. What other questions are you posing to gauge potential alcohol use disorder?
Yeah, that's a great question. You can ask about binge drinking. And I think that's what you mean in a 24-hour period. It's usually like, when you sit down in an evening in a 2-hour window, do you drink more than 4 drinks? And that's a definition of binge drinking. And that's also, it has harm. Even if it's intermittent, it can cause a lot of harm. But I wanted to, if you don't mind, just to kind of go back to how women are affected differently. And I think it's important, especially in your series about addressing specifically, the women population, is that our body compositions are different than men. And so we have less body waters, and that, there's more concentration in the blood as a consequence. There's some theory about where we are during the menstrual cycle may affect how the rewarding aspects of alcohol are perceived and affect us. So hormonal changes affects how alcohol is metabolized in the body as well. We suffer, girls suffer a lot of more trauma than men in general. And so that will also increase our risk for developing a use disorder later on.
Yeah, and I think that's again so important to emphasize because, having early trauma, whether it's an adverse child event or suffering from intimate partner violence affects how women use substances. Do you have any suggestions on how we should be screening for childhood, early trauma, history of intimate partner violence?
Yeah, thanks for asking that question. I was, it was interesting to learn um, how ACOG advises how to screen for intimate partner violence. They say, first of all, to do it privately, not with the partner involved, and that's common sense. But they also say to avoid terms like rape, abuse, violence that may stigmatize, and to frame it more like a safety. For those who do this often, this is common sense, but I think it was interesting how language matters to allow the woman to feel safe. And so to ask it in those ways, like, have you been hurt recently? Um, I'll often ask, I'll start with where were you born and raised, and what was it like growing up? Was it a warm household? I kind of phrase it that way. And then, that'll maybe trigger a response, and then the floodgates open for them to tell a story of how it was growing up.
Okay, I like that a lot. I will be using that more. What was it like growing up? And then, like many chronic medical conditions, it's important to gauge how ready our patient is to make a change and not just tell them that they need to make one. What
Mhm.
verbiage or motivational interviewing tactics are you using to do this when addressing substance use?
So this is the practice of medicine. I'm still practicing motivational interviewing and honing that skill. A key of MI is rolling with resistance, and that depends on the day and at what time of day I'm seeing patients. It's challenging to roll with resistance, but it is really important to roll with resistance, and to respect someone's autonomy and agency. So I try to ask as many questions as possible. It's all about getting to understand what the patient wants, what she wants. So why are you here to see me? How can I help you? What changes do you want to make? So it's really active listening, and then building on their own awareness. Um, so, so that's some of the verbiage that I use, and also to remember that it's a long game. So often we feel like we have to fix something in those 20 minutes or 15 minutes, and really it's building the relationship. A lot of the times we don't want necessarily someone to fix anything right away. Actually, some patients don't even want to stop using; they're just here for informational gathering. And so patience, compassion, empathy are key.
Yeah, yeah, I love that you said that because sometimes it takes 3 or 4 visits to even get someone on a statin. So how do I expect them to, decrease drinking after one visit?
That's right. I'm glad you brought that up.
And despite these increasing rates of alcohol use disorder in women that you mentioned earlier, there's pretty low rates of treatment utilization in the female population. And this is in part due to continued stigma around women drinking, particularly, let's say, pregnant women or mothers. And women might be fearful of seeking treatment due to, for example, fear of child protective services. Can you talk more about how shame, stigma, and other barriers affect access to treatment in women?
Oh my goodness, that's a very loaded question. How do I start? Well, first of all, 46 million people in the United States have substance use disorders, and the majority alcohol, and only 6% receive any treatment. So it's a global issue, not just for women. But for women, they seek treatment even less so. I think it's important to create safe environments so we know that residential treatment facilities, aka rehab, that are women focused, that you take care of their children, you have childcare, you talk about intimate partner violence, trauma. Those facilities do better. Women have better outcomes. So really targeting women-specific treatment. I like to tell this story, and this pertains to pregnancy, about checking our own assumptions and our biases. So I was applying for med school a long time ago. And this was actually my first interview, and they allowed us to sit in on a med school class. And so it must have been a first or second year because it was a didactic. And there was an OB-GYN at the bottom of this huge amphitheater. And she said, before you judge that pregnant teen, so she was talking about teenage pregnancy, before you judge that young woman or girl, how dare she smoke cigarettes while she's pregnant? How dare she drink and use drugs? But for the grace of higher power go I, you should be thinking. And then she pointed to this chalkboard. Well, that's what they had, this blackboard. And it said on it, like, hey, let's party tonight after class at such and such bar, see ya, be there, whatever. And she's like, what is that? And then there was kind of this nervous laughter and then dead silence. She really asked us to examine our own habits before we judge somebody else. And it is a sensitive area, this lifestyle thing. And so there's a lot of stigma around substance use in all aspects of society, including medical training. And so we really need to support each other about talking about it, being open about it, about addiction, and that it's not a moral failing. I think first and foremost is just getting out there and talking about that.
Yeah.
I hope I answered your question.
Yeah. I mean, it's definitely difficult, but important not to pass our own judgments to really any situation. And how can primary care providers identify harmful alcohol use? Are we still using things like the CAGE questionnaire?
Right. No, not really. Well, the CAGE, when I teach, I say that's like sort of the tumor is like visible, and then we're doing a screening. Like, oh, maybe they have cancer. Yeah, duh. Yes, they do. We use Audit C and such, but I've seen so often even just mildly elevated liver enzymes, AST, ALT, go sort of unnoticed for many cycles of annual visits, and macrocytosis kind of go unchecked. And so they may be sort of small flags, orange flags, maybe not red flags, but yoo-hoo, check it out. Yeah, so, and I also, sorry, I keep going back because your questions keep ringing in my mind about like custody issues for women. And it's not unfounded because we have these laws that aren't empathetic to women. And it's punitive custody matters affect both the mother and the father often. And we really need to find ways to kind of keep the family cohesive and then support the family unit through this process of addiction when possible. Of course, if the safety of the children or the child is an issue, yeah, that takes precedence, but really trying to support the family. That's what I was thinking.
Yeah, no. So we've talked a little bit about the barriers to accessing treatment, and I wanted to talk a little bit about the different kind of levels of treatment for alcohol use disorder. We think of like
Sure.
inpatient hospitalization, residential rehab, intensive outpatient program, and then outpatient treatment, which is what I want to focus on. But how do we
Mhm.
determine if a patient is safe for outpatient treatment in our clinic setting?
I, I think it's about exercising good clinical judgment, which I think most of us have here. I would consider whether the person has had seizure before from withdrawals, delirium tremens, history, cardiac issues, hepatic failure, immunocompromised, serious comorbidities, elderly patients. You want to consider safety at home in doing this. Do they have supports? And also, let's not forget patient preference. Some people, I want to send them to the emergency room and they won't go.
Right.
And so you have to weigh the risks and benefits. Will you allow them to just go through uncomfortable withdrawal? More likely, they will just continue drinking. And so I've had patients just say, like, you know, please give me something. I do want to stop, and I promise I will, call so and so, and I will be in touch. And so I will do this as an outpatient. It's actually very manageable. I think there's sometimes a lot of fear about managing outpatient withdrawals. But when I worked in a large HMO system, and that's all we did a lot of the time was just outpatient alcohol withdrawal.
Yeah, and I recently had a patient discharged on a camprosate, and I have to say I'm not very familiar with it.
Mm-hmm.
So, and I know I've also read that naltrexone may be preferred over things like anti-abuse, which I think most of us are a little bit more familiar with from training. So, how do you start talking about medications like anti-abuse, naltrexone, a camprosate? How do you decide which agent? What are the contraindications we should keep in mind?
Sure. So there was a large study, the combined trial, and that studied naltrexone versus a camprosate, which you just mentioned. In that study, back, I think it was like 2006 or 2008 that it was published. It didn't show a camprosate as being that efficacious compared to naltrexone. I mean, and that was studied against. There were many arms of that study. There was, medication management, cognitive behavioral interventions, and it showed that a camprosate didn't do that well. But if you look at European studies, they have more robust data for the efficacy of a camprosate. Um, Also, what was interesting was that the study drug, so the acamprosate dosage was a lot more than the FDA approved what we use, and the naltrexone dosage was 100 milligrams. So that's double what we use now. That's FDA approved, which is 50 milligrams. So I do prefer naltrexone. I do see better efficacy with naltrexone. Um, but I'll often see a camprosate in those with liver disease. So was this person, did they have alcohol liver disease? Was
Yes.
that why they were on a camprosate? So that's usually the go-to because it's renally cleared. So you have to
Agreed.
make sure that their creatinine is above 30. So GFR, not the creatinine. The GFR is above 30. So that they have good renal function to clear the acamprosate. Um, but so many of my patients drink through a camprosate or forget to take it. Adherence is a huge issue with a camprosate. It's like 2 pills 3 times a day. I don't know about you. I can barely remember, who takes, sometimes you forget, the days we took vitamins, like, and so adherence is an issue. So if you're, that's 2 grams for a camprosate a day. The study was 3 grams. So here we are using less than the study, and the study didn't do so well with the camprosate. So I
Mm.
start to scratch my head and wonder, like, is this placebo? What's going on? What's good news is that a study out of Yale showed that naltrexone is safe in cirrhosis. And so just, that's an option that's opening up, and you just have to maybe dose a little less. I often start naltrexone at a lower dose anyway because of the side effects, which is nausea and sometimes a wooziness. So I'll tell patients to take 25 milligrams at dinner time and kind of sleep through the side effects. And then if they tolerate it, then increase the dose to 50. Now, if 50 is sort of working in terms of curbing cravings or the compulsion to use, this is naltrexone now, but it's not quite there and they want to see better efficacy, I'll creep up the dose to 75 to 100 because the studies used 100 milligrams.
Yeah, yeah. Okay.
And then did you mention antabuse?
I did, yes.
Oh yeah, so that's kind of third line. Um, it, I'll use it if a patient asks for it, number one. I'll use it in most cases if there's a rupture in the relationship and the person with the use disorder wants to heal that rupture by allowing their partner to see them take it, witness taking it, and then they're sort of like done for that day. Like, I'm good for today. I will not be drinking today. We just kind of can get that off the table. If you're living alone, if you don't take it, it's not going to work. I also see people drink right through it. And so, yeah, there are also contraindications. So you wouldn't give disulfiram for coronary artery disease or heart failure, or psychosis, renal and liver failure. Also, you have to be cautious. I don't use it in those circumstances. And for pregnancy, it's all category C.
Okay.
And then lactation also not advised.
Yeah, that's interesting that you would be more apt to use anti-abuse if there's a relationship rupture, as you mentioned. And then I've also heard, I was listening to a few other CME episodes on substance use disorder while preparing for this, and I heard it kind of compared to other chronic medical conditions like diabetes. And we don't ever really consider diabetes cured when we have like one A1C at goal. We continue to, monitor labs, check in about lifestyle factors, etc. So similarly, we shouldn't consider like alcohol use disorder cured when someone comes out of a residential or IOP program. What should be included in a kind of a long-term treatment plan for women who might be recovering from alcohol dependence?
I think you've basically said it. It can be folded into primary care. Although I understand, I used to do primary care, the burden of primary care, it's just one more thing that I have to monitor. But it is like that, though. It's a chronic disease, just like you mentioned, like diabetes. I often will offer mutual supports if they're open. It can be 12 steps, although it's not for everyone. It's highly effective, but not for everyone. So there's also Women for Sobriety, a large organization that they can participate in. There's Smart Recovery that is not Christian based. It's cognitive behavioral based. There's individual therapy, group therapy. Sometimes if somebody goes to an IOP or a residential, there's alumni groups that they can continue checking in once a month. I wouldn't underestimate your relationship with the patient being powerful and treatment in and of itself. One of the arms in the combined trial was just management coming in to see the physician or the provider. And so I have some patients who refused any other treatment except to just come in and see the doctor and maybe a therapist, and they can remain abstinent for this one patient I'm thinking of 11 years on a relationship alone.
Yeah. I still remember sitting in on some AA meetings in med school, and those were very powerful.
Yeah.
Yeah. So, but that's good to know. I didn't know about like Women for Sobriety and Smart Recovery you mentioned.
And there's LifeRing, there's Dharma Recovery. There's a lot more out there, and there are app-based supports. So Digital Health Sphere, there's a lot of supports there as well. Okay. And then you can use like well, let's not forget lifestyle management. We counsel on exercise, eating well, just group activities. Who are your peeps? I always say, who are your peeps to support you? There's acupuncture, massage, all kinds of things.
Yeah. Okay, great.
And yoga. Yoga.
Sign me up for all those things. Massage, yoga, I'm there. So I wanted to shift gears and talk about opioid use disorders. My first question is, how can primary care providers differentiate between appropriate use and potential misuse of prescribed opioids for chronic pain?
I believe in universal precautions. We've done a really great job in reducing the amount of opioids we've prescribed, although it didn't really change overdose. That landscape was affected by fentanyl. And just cutting off patients was also probably not the best approach, but universal precautions, because these are powerful medicines. Opioid analgesics are absolutely useful. They're helpful. They have a utility, but they're a medicine. And we monitor all kinds of agents. And so I think monitoring and doing universal precautions and limiting the amount and really kind of seeing patients back and understanding where their pain is and do they still need this medication is really helpful. There are screens. Um, there's the opioid risk tool, which is controversial. And I don't understand why in the screen, sexual abuse is given points for females, but not for males. And so there's controversy there. You want to screen for current substance use because that increases risk for developing a use disorder for opioids. So that includes everything: stimulants, benzos, alcohol, cannabis, tobacco as well. And you want to understand their past substance use history. If there is any trauma, especially sexual trauma, as I mentioned, psychiatric history. If you're of a younger age and starting opioids, that's a risk for developing a use disorder later on. Your level of education. Interestingly, Medicaid insurance coverage and self-pay is an increased risk. Also, Caucasian race. So these are just statistical analysis of who have developed opioid use disorders who are at higher risk.
Yeah.
Yeah.
And then, what is some of the verbiage that you might use for someone who might not see their opioid use as an issue and feels that it's necessary or even beneficial for their chronic pain?
Sometimes I use, and I probably should use more, the Reassured risk tool. It's a VA analysis of data of all those who have used opioids. There were two iterations, one for the VA population and then later the commercially insured, and it included millions and millions of patient data. It's the risk index. Okay, let me see. Reassured risk index for overdose or serious opioid induced respiratory depression. That's a mouthful, but it's a really the visual of it. I'll pull up the screen in front of the patient and say, okay, so you have a substance use disorder, whatever it is, alcohol, tobacco, whatever it is, and you get 25 points. In the second version, you get 25 points just for having a substance use disorder. You get points for having high dose MMEs, for renal failure, for psychiatric disorders. So you accumulate all these points, but just having a substance use disorder gets you 25 points. And that corresponds with a 30% average risk of having an overdose or serious respiratory depression event in the next year. So I think that's a powerful message that I'm concerned about your overdose risk or some respiratory depression risk. It sends a message that you care about their health. And so that is sometimes an inroad of asking someone to start the taper process. Like, can we get it to a lower effective dose? I'm not going to cut you off, but can we, is less more at this point?
Yeah, yeah. And then there's various types of pharmacological therapy that we can use for opioid use disorders, including methadone, buprenorphine, naltrexone. Can you go over the different physiology for these meds and then how you explain this to patient and then decide on an agent with them?
Oh my gosh, that's a huge question. That's a different CME. Sure. So the question is, what will I choose?
Yeah, how do you choose one of those three agents with your patients and kind of keeping in mind the physiology of them? Because I know, some of them are partial agonist, full agonist, antagonist.
Yeah.
Confuses me that you can use all types of those for the same
Yeah,
disorder.
exactly. So methadone, and this is for opioid use disorder. Is that correct?
Not
for chronic pain.
Yes, for opioid use
Opioid
disorder.
use disorder.
But you could
So
comment on chronic pain as well, which
yeah,
is so common to see.
right. Let's talk methadone first. We cannot do that in the outpatient setting for opioid use disorder. So that's highly regulated. It has to be in a federally sort of, federal um, a center. It's the methadone clinic.
Right.
And so that's not an option in the outpatient setting, even for me.
Mhm.
Although during the pandemic, uh, federal laws and regulations were relaxed tremendously, and they're still in effect, like take homes. It's really onerous to go to the methadone clinic at 5 in the morning, stand in line to get your one dose of the day. And so there's this concept of take homes, and you have to earn the take homes, and it's just very paternalistic. And so we're trying to advocate for allowing addiction medicine docs who are certified and have training to do it in the outpatient setting. But there are a lot of legislative hurdles to do that. But in the interim, during the pandemic, we allowed more take homes, and we're allowing that. And so if someone needs greater level of sort of wraparound care around their use disorder, methadone is a good choice. Now, um, for fentanyl use disorder, buprenorphine doesn't seem to be as effective initially. You just need methadone it's been found to be more effective. And so if that's the case, then sending someone to methadone clinic. And so that's how I'll choose that. For buprenorphine, I think that's in the outpatient setting in primary care, we could be using more of it and giving more access to buprenorphine. It has better neonatal outcome, and that was shown in the mother trial. And then later on here, a study between Harvard and Stanford collaborated and found that you get better outcomes in the neonate with buprenorphine. It's also lactation safe, pregnancy safe. Patients will tell me that they feel more normal on it. And this could be because buprenorphine, you mentioned a partial agonist, doesn't upregulate or doesn't recruit the beta arrestin pathway. So I'm just geeking out a little bit here. And it's like, I'm wondering if that characteristic of buprenorphine confers sort of less of the untoward side effects of full agonists, that they kind of feel normal. What I would love to see is like a head-to-head trial between buprenorphine and methadone on quality of life, and how that does. So we could be using buprenorphine more and having more access to buprenorphine. And then naltrexone for opioid use disorder, it's not well adopted, and it's scary to patients. They have to, if you're using opioids actively, you have to be in withdrawal, like off for 7 to 10 days. So there's this washout period of the opioids. You're craving opioids. You're in withdrawal. How are you going to sustain that for 7 days? You can barely sustain it for a day. But that's the ask of someone to transition to naltrexone. But in certain settings, sometimes, the carceral setting, for those, it's effective, and physicians will choose that for their opioid use disorder. It's highly effective. The downside to naltrexone is that it reduces tolerance. And so someone has a notion, oh, this is my daily use dose. Like I use this many oxys usually, or I use this much heroin on a daily basis. And let's say they return to use, they may forget that their tolerance has just been like wiped out on the naltrexone, and boom, they overdose.
Yeah, and I think for some of my patients who have switched over to buprenorphine or naltrexone, they're nervous about, well, what if I end up in the hospital for whatever pain? How's my pain treated then? How can we, first of all, prevent patients from going to the ED for their chronic pain? And then how do we talk to them about those situations or flares or injuries where they may need increased pain control?
Buprenorphine When I use it in patients with, I've had patients who have sickle cell, juvenile arthritis, kind of rheumatoid disorders that have chronic pain or abdominal pain, chronic abdominal pain. Once they're on buprenorphine, they do visit the emergency department less. Um, I think just the use of buprenorphine will oftentimes reduce ED presentation. I don't know how you can prevent someone from going if they have to go. I think the medicine itself, buprenorphine, has that effect on people. It's a good pain relief, and you can get full agonists while being on buprenorphine. Um, there's no need to, like, let's say perioperatively, you don't have to taper your buprenorphine anymore. We don't ask people to taper off before they go in for surgery. We just keep taking it. You may want to reduce it if it's really high dose, like 32 milligrams. You want to maybe come down. But for the most part, we don't taper people on buprenorphine. They can get their full agonist in the hospital post-op while still taking their buprenorphine. Was there, pain control. Yeah. If you're on naltrexone, that's a different story. Usually we have wristbands that say, oh, I'm on naltrexone. With EMRs now, people can see it flagged in their chart that they're on naltrexone. That's a real fear. Naltrexone is a full blockade.
Yeah.
So, yeah.
Okay. And I know this is a very complex, individualized topic, particularly since you've walked me through this process for so many of my patients. But how, in general, do you transition patients from their opioids to buprenorphine?
The simple answer is I've gotten into the habit of using the patch, the transdermal form. I think it's for me a convenient way. It really all depends on what insurance will cover. The transdermal form, the microdosing is what it's called. So introducing buprenorphine very gradually in small doses so that you reduce the chance of precipitated withdrawal, and you don't ask somebody to come off before. That's the way we used to do it. Is like, oh, I'm so sorry, you're going to have to be in withdrawals and feeling just awful before I can initiate buprenorphine. It's just not humane. um, to ask someone to do that. And so microdosing using the patch is a softer, gentler way of making that transition and increasing the patch dose over time while they are still using their full agonist. And this is for the chronic pain patient that you and I have shared, right? And so and then just making that transition and then introducing the sublingual form or introducing the buccal formulation to continue introducing the buprenorphine slowly. And what's amazing is that they taper their full agonists actually fairly rapidly.
Okay. So is it kind of like for example, for like nicotine replacement, I have people on the patch and then I use kind of a PRN gum or lozenge. Can I think about that similarly in terms of the buprenorphine patch and then the
Yeah, and then they stop, then their smoking kind of gets lower and lower. I think of it actually more like varenicline.
okay.
Varenicline does all the heavy lifting. I sometimes just tell patients, don't think about necessarily quitting. Like you don't have to like commit, like my quit date is going to be in 7 days. Just take the medicine and see it do its magic.
Yeah, and then at Stanford, we're just so lucky to have you as a resource, helping us patients transfer to buprenorphine. And I send you messages all the time. But for our listeners from other areas, how can they receive training on buprenorphine use? What online resources can they use to help determine dosages and such when they're transitioning patients?
So even though we're no longer required to be certified to prescribe buprenorphine. That data waiver has gone away. There is still the PCSS website, that 8-hour training that's free online. And so you can get materials there on how to use buprenorphine and make that transition. The American Society of Addiction Medicine also has CME. We have CME here at Stanford, and a terrific resource is the California Bridge program and that website. I don't know what you're going to make available at the end of this podcast, like maybe like a slide or something. But you just type in California Bridge program, and it has like these really easy way to follow how to make transitions, even self transitions for patients at home, transitions to buprenorphine.
Okay. And then I wanted to make sure we covered benzodiazepine and sedative hypnotics in our last few minutes. And what I've seen practicing primary care in the Silicon Valley is that almost everyone struggles with insomnia, anxiety, or both. And it takes a lot of time to counsel on appropriate sleep hygiene, wellness habits, talk our patients into a CBT program. And so it's often easier for patients and providers to prescribe an anxiolytic or sleep aid. Um,
Mm-hmm.
and there's now a higher prevalence of a hypnotic and sleep aid use among women compared to men. Can you comment on potential reasons for this?
um, Potential reasons why they are getting more benzos. That's a
Mm.
fact. I mean, statistically, they do get more
Yeah.
benzos. I'm wondering if part of it is historical. If you do an online search of old phenobarbs and benzodiazepines, they specifically targeted women. Like there is this one ad that says like, you can't set her free. So it's like a black and white of like broomsticks and like all these cleaning equipments, and she's wearing like this kind of like handkerchief, and she's obviously a housewife. And it says you can't set her free, but you can help her feel less anxious, which is oxazepam. And so I think women, um, to manage their hysteria and their, nervousness, were targeted for these drugs. And I wonder if that's persisting.
Yeah.
They do also have anxiety. It's more prevalent. Um, and all, but I know, men have anxiety. It's just maybe the way we're societally sort of conditioned. But that's one difference I can think of, the way we've been targeted, and just these gender expectations.
Yeah. And then can you talk about some of the risks of chronic benzo use and non-benzodiazepine sleep hypnotics?
The data shows that the risk is with falls, possibly cognition, suicide risk, with the Z drugs, the hypnotics, as well as benzodiazepine. Um, Chronic use creates dependence, and I would say that coming off of benzodiazepines is far, far worse than coming off of opioids. There's this phenomenon called bind, uh, aptly named bind, benzodiazepine induced neurologic dysfunction, where even after someone comes off of the benzodiazepines, they have residual symptoms. You could call it post-acute withdrawal syndrome, but it's just some patients have continued persistent paresthesia, for example, continued anxiety, photophobia, all kinds of symptoms from chronic benzo use, even after they've stopped. And so that's a huge risk, the dependency um, to that.
Yeah. And then what are some indicators of benzodiazepine or sleep medication misuse?
Oh, it you look for the same things for all kinds of substance use. It's you look at behaviors. Is it reasonable? Are they dose escalating so rapidly, constantly losing prescriptions, needing earlier and earlier refills, um, ED visits, behaviors that are unreasonable. Um, threatening behaviors. And you also have to look at why, though, and not to ignore. Is this behavior like a flag for help, and finding out what's going on? Sometimes people divert or sell these prescription drugs to just to pay for bills. Um, there are all these social determinants that we don't account for. Maybe just for transportation money to get to your doctor's appointment. So I, I hesitate. It's like, yes, we have to be cognizant of misuse and escalating use, so that we are treating a use disorder, and at the same time we have to be compassionate about, like, we just have to be more aware than just kind of pegging somebody as like, oh, they're just a difficult patient.
Yeah, yeah. And I thank you for reminding us all of that. I think we're all kind of guilty of maybe being a little punitive if someone's asking for early refills or whatnot, but keeping in mind their kind of financial situations or other distress that they may be going through that's causing them to need early refills, I think is really important.
And we have to be mindful of our system's way of doing auto refills. And don't get me started on how broken our system is and how we have to save time. But I don't quite understand if a patient says, oh, I rarely use it, and you can see it in the chart, rarely uses it for like airplane rides, and yet you check the PDMP, right? It's like every month, like clockwork, 30, 30, 30. We know the statistics show that most people get their benzos from friends and family. Sharing is caring.
Yes, in some ways. And then, so, I find that a lot of my patients who've chronically been on alprazolam, clonazepam, zolpidem, it's very difficult to kind of get buy-in from them that there's safer alternatives because they feel like it's working. And then also, like you mentioned, when they stop it, they have these kind of symptoms.
Yeah.
Do you have any tips on navigating those conversations and trying to encourage patients to taper off or switch to other agents?
Uh, well, we know what other meds are in their regimen. We can talk about drug-drug interactions. We can look to see if there are other comorbidities we can address and just voice our concern. We can reassure them that we will not cut them off, but can we start to taper? Um, things like that to get buy-in. Are we noticing changes in cognition? Are we noticing are they drinking alcohol and using benzodiazepines? Um, it's creativity in medicine. This is the art of practice, is just understanding the patient and what are they using it for? Can we work on that?
Yeah, and I still remember a time that I called you maybe 5, 6 years ago, and I had someone taking, like 150 tablets of Norco a day, and you had advised me instead of just I always thought of it as, okay, if they're taking it 5 times a day, I'll taper down to 4 times a day. And you kind of taught me to taper down, like, for example, 4 or 5 tablets a month, and that has been a really useful tactic.
Yeah, it's manageable. Percentage wise, it's barely anything if you think about it. And
Right.
you give the patient autonomy, agency to like pick and choose. Like, truth be told, most of us forget or skip a dose here and there. We hoard our medicines. I don't know how many Cipros from my travels that I have. People save medicine. You just give them a little less to save, and you say, you pick which one you want to like cut a quarter. If you give, you know, like 2, 3 less, they're just going to take a quarter less a week. That is
Yeah.
absolutely manageable. And what's the difference? Like if you were going to refill for the next 10 years at 150, if that was the original plan, going down increments at a time, 10 years will pass and they'll be off.
Yeah, yeah, I have found that so useful. And then are there any other resources you utilize to help you taper patients off of benzodiazepines?
The Ashton method, early on when I was, early in practice, trying to find a resource, the Ashton method, you can just look that up online. The American Society of Addiction Medicine will be coming out with a guidance. I happen to be on that working group writing the guidance. And so, labor of love for all the physicians that are on that team and nurse practitioners and PAs. And so, stay tuned. There will be some guidance on benzodiazepine tapering, deprescribing.
Okay, great. And then kind of looking ahead, are there any advances or new treatments in addiction medicine that you're excited or hopeful about?
Well, what can't the GLPs agonists do?
Yeah.
There are a lot of studies now. Currently, um, the jury's still out on whether or not they're effective for substance use disorders, but there is promise for substance use disorders. It's being studied in alcohol use disorder. It has been studied in cocaine use disorder, nicotine, and it has sort of contradicting outcomes. So we can't really recommend GLPs, but I'm excited to see what is on the horizon for the GLP agonists. I'd like to see AI, large language models, being leveraged for predicting outcomes, seeing like choosing treatments that match the patient's, personality, or choosing medications that will better suit a patient. Using that leveraging that kind of technology. We have like transcranial magnetic stimulation that's used for depression, and it's been studied and used for substance use disorders. There's also like focused ultrasonography, um, so other sort of neuropsychiatric interventions would be interesting. Um, there isn't a lot, unfortunately. Like what the FDA has, like 6 or 7 approved medicines for substance use disorders, like 3, like we've talked about them, like 3 for opioids, 3 for alcohol, varenicline for tobacco, some off-label stuff. And you compare that to what, 300 drugs that were approved for biologics for cancer in I don't know how many years. And so many of those cancers can be attributed to these lifestyle things like alcohol and tobacco. And so it would be nice to see more research in pharmacologics, and there's vaccines that are being explored and stuff. So I'm looking forward.
Yeah, great. And so thank you so much for your time today and sharing all your expertise.
You're welcome.